All right, now that we started recording, I will say good afternoon or good morning to everyone joining us today. My name is Ellie Stout, and I direct the Prevention Support Team here at SPRC. And it's my pleasure to welcome you all here today for our webinar on collaboration between substance abuse and suicide prevention efforts. And before we get started, though, I'm going to hand it over to Zoe Baptista to give you a quick overview of how to use some of the tools on the webinar platform as we move forward.
Hi, thanks so much for joining us. I just wanted to let everyone know if you have any technical problems, please call us at SPRC at 617-618-2380 or Adobe Connect at 1-800-422-3623. These phone numbers are also in the bottom left-hand corner of your screen. You can type any questions you have at any time in the Q&A box on the left-hand side of the screen, right underneath Ellie Stout's lovely photo. Finally, at any time during the webinar, if you want to make your presentation screen larger, you can click this full screen button, which is right above this green arrow where I'm hovering, and it will make your screen larger. And if you want to make it smaller again so you can see all the other areas of the presentation, just click it again. Thanks so much.
Thanks, Zoe. So once again, I'm Ellie, and I'm going to be your moderator for today's webinar. And we're also very pleased to welcome our three presenters who will be sharing their expertise and experiences. Eileen Zeller is the lead public health advisor for the suicide prevention branch at SAMHSA's Center for Mental Health Services. Patti Clark is the project coordinator for Kentucky's Garrett Lee Smith Grant. And Tahoot Salamab works for us part-time as a project manager here at SPRC. And she also spends the rest of her time working with the Center for the Application of Prevention Technologies, which is a SAMHSA TA center working with substance abuse prevention efforts across the country. So she sort of bridges both worlds for us. And before we get into our specific content for today, we wanted to also get a sense of who all of you are and the experience that you're bringing here to our virtual room. So if Zoe can pull up the poll for us. We'd like to know how many of you have experience collaborating with your substance abuse prevention or treatment partners in the community. So if people are already voting, which is great. If you can just click on the choice that represents you most closely. I'll give you a couple more seconds to let us know your experience. Wow, it's really very balanced with a little bit of weight toward a great deal. That's wonderful to know that a lot of you are already doing a lot with your substance abuse prevention or treatment partners. And for those of you who haven't done anything, that's fine too. We know that everyone's at a different stage in collaborating, and that's part of what we'll be talking about today. So we can go ahead and close the poll. So today we want to share a few important things with you around this kind of collaboration, why it's so important, and some new tools that we've developed to help you move your collaboration efforts forward. So Eileen will be giving us an overview of the connection between suicide and substance use, and she'll also share some of SAMHSA's perspective on the importance of connecting programs that focus on those two health issues. Then we'll hear a bit from Patti about her experience in Kentucky, connecting her Garrett Lee Smith work with existing substance abuse prevention efforts and how that benefited both partners. And then last, but definitely not least, we're very excited to be giving you a sneak peek of our new web pages on collaboration between substance abuse and suicide prevention. This is a new part of our website that we've designed to support grantees and others in the suicide prevention field in better connecting with their substance abuse prevention and treatment colleagues. So we're very excited to share that with all of you for the first time. We do have the Q&A box to the left of the slides, and I encourage you as questions come up even during the time when our presenters are speaking to please go ahead and type in your questions or thoughts. It's to the left of the arrow that Zoe is using right now. I'll be monitoring your questions, and we are pausing at a couple of points for some Q&A, so please go ahead and type those in as they come to you. And also that brief pause at the beginning was because we are recording this webinar, so you don't need to scribble down a lot of notes. We'll be posting the archived recording on our website after the event. So with that, we're going to dive a bit more into substance abuse and suicide, and I'm going to turn it over to Eileen.
Thank you, and thank you all for joining us on this afternoon's call. I've got 10 minutes to talk about the connection between substance abuse and suicidality, to talk about contributing and predicting factors, the future of healthcare, SAMHSA's perspective on it, and to talk about why GLS grantees, why are you important to this. So I'm going to dive right in. As you can see, and most of you are probably really familiar with the data on this, but if you look at risk factors for suicide, substance use is second only to depression and other mood disorders in how it's correlated with suicide. If someone has a substance use disorder and a mental illness, that kind of comorbidity is going to increase the risk even more. We know that in about 30 to 40% of suicides and suicide attempts, alcohol is involved. That doesn't necessarily mean that that someone is a chronic user. It could be binge drinking. And we do know that both binge drinking and chronic use of alcohol are associated with suicidal behaviors. Substance use can increase the risk of suicide by intensifying depressive thoughts or feelings of hopelessness, and at the same time it's going to reduce the inhibitions against hurting yourself. It can also heighten impulsivity and cloud people's judgments about the long-term consequences of your actions. And so those of us on the phone, we all work with young people, and I know you're all identifying with this as I'm saying it. Next slide, please. Suicide, if you look at people who do have substance use disorders, suicide is the leading cause of death among those folks. If you look at just people who are alcohol dependent or who abuse alcohol, they have about a 10 times greater risk of dying by suicide than the general population, and it rises to about 14 times a greater risk for people who inject drugs. It doesn't seem that the type of substance that people are using is as important as the number of different kinds of substances. Next slide, please. Again, I think that you all know this. If not, if you haven't read the articles, then you've worked with the people and you know this intuitively. We're dealing with the same population, people who use substances and people who make suicide attempts and die by suicide. The shared risk factors include a family history of suicide or child abuse, a history of mental disorders, especially depression and mood disorders. Oh, that's good. A history or family history, not of addition, but of addiction. Sorry about the typo. Impulsiveness, feelings of isolation, lack of connectedness, barriers to behavioral health treatment, financial losses, relationship problems, social problems, problems at work or school. Any kind of long-term physical illness or chronic pain can increase both the use of substances and the risk for suicide, access to lethal means, and among young people, delinquency. Next slide, please. In the shared protective factors, again, it's the same elements that can help both of these populations and the intersecting population. The social support, the connectedness to people, to communities, to institutions, coping skills, life skills, problem-solving skills, whatever you want to call them, positive parental involvement, any kind of trusting relationship with an adult, be they a counselor, a physician, another service provider, employment, and if you believe in religious teachings that say, for instance, that suicide is a sin, that's a protective factor against suicide. Next slide, please. So why is this important? Mental health and substance use providers are seeing the same populations. If you're talking about the students who come into your health center, they may come in with a hangover. They may come in because they have they're being bullied. They may come in because they're having roommate problems. They may come in because their mom and dad were drunk again last night. It's the same population. Whatever their presenting problem is, we need to go both ways. If they're presenting with a mental health problem, we need to ask about substances. If they're presenting with a substance use problem, we need to ask about the mental health piece. It's important because we know that for co-occurring disorders, when you integrate treatment for people who have both mental health and substance use conditions, you can see the list in front of you. We know that we have positive outcomes: reduced substance abuse, improved functioning, decreased hospitalization, fewer arrests, improved quality of life. We know that. We know less in terms of research right now about combining primary care with behavioral health care. But next slide, please. But we're doing it, and again, it's the trend. It's where we're moving in this country towards integrated and coordinated care. So at SAMHSA and our sister agency, HRSA, we have the Center for Integrated Health Solutions. At SAMHSA, we take behavioral health settings and we bring primary care into them. At HRSA, they're the folks who have the federally qualified health centers, primarily in rural areas and underserved areas all across the country, and they take their primary care settings and they bring behavioral health care into it. The Affordable Care Act, whether you're for it or against it, what it's doing is it is creating health homes, and health homes are a place where all care is going to be coordinated. They will assist with care coordination, and that will include both prevention and wellness services. The prevention services will include depression screening, tobacco cessation, and a model called SPRC, which many of you probably know about it. It's a brief screening and intervention for substance use that has been shown to be effective. Another piece of the Affordable Care Act are accountable care organizations. It's similar to a health home in that it also coordinates care, but it also creates a structure of paying for the care and offers incentives for cost savings. Plans purchased through health exchanges that will become active in 2014 have to include mental health and substance abuse treatment. So by combining forces and working with our colleagues in the substance use field, we can save lives. Next step. For instance, if we could prevent the 30 to 40% of suicides that involve alcohol abuse, that would be about 13,000 lives a year if we could do that. And why GLS grantees? Next slide. You all are working in the public health model. You are accustomed to the collaboration. You can impact suicide mortality not just by working within your organizations, but by reaching out also into, for instance, policy changes. So we know that suicide mortality can be impacted in changes in alcohol control policy. So the one that most people are familiar with is that if you increase the drinking age, that is associated with a lower mortality. So working in the public health model, those kinds of tools are familiar to you. The collaborative framework is something that you do on a daily basis in your grants. Substance use professionals may not be acquainted with suicide prevention programs and the personnel in their state, so you can reach across the aisle. There may be a reluctance to make the relationship between substance abuse and suicide explicit because of concern that funding may be redirected, but you can look beyond that. Substance abuse professionals may not understand how important their efforts are in preventing suicide. You can show them how important they are by working together with them. I'm really pleased that on this webinar today that we're going to have a wonderful model for success that, that you'll be able to hear and I know identify with and hopefully share some of your own. And the new tool that the Suicide Prevention Resource Center has come up with, I think is going to be game changing. So I'm also very excited to be a part of that revelation. And with that, I will turn this back over to Ellie.
Thanks so much, Eileen. I did want to pause at this point and see if there were any questions. I haven't seen any typed in yet, but I'll give people just a moment in case there were any questions for Eileen before we move on to hear a bit about the experience in Kentucky. Oh. And just as a reminder, we are recording the webinar and we'll be posting it online, but certainly we can also share slides for people who are interested in having a copy of the slides. All right. Well, thank you again, Eileen. That was a great overview in a very short time, so we appreciate your expertise. I'm going to turn it over now to Hoot, who's going to do a little interview with Patti to talk a bit about the Kentucky experience.
Sorry to jump in. Sorry to Hoot, just to jump in. This is Zoe. I just want to let you guys know also that the Q&A pod for this portion will be in the lower part of your screen. Thanks. Go ahead.
So, thanks, Ellie and Eileen. As Ellie said, my name is Tehut Salamab, and I've had the pleasure of working on this project with this wonderful team for the past year. Before we get into the resources that we've developed for all of you, I'd like to start with a conversation with Patti and hear a bit about her work in Kentucky. Patti is the project director of suicide prevention efforts for adolescents in Kentucky. So welcome, Patti. A lot of you may know Patti. So thanks for being here today, Patti, to share what you've learned about building collaborations with substance abuse partners.
Thanks, Tehut.
So before we delve into this topic, I just wanted to give everybody a very brief overview of your GLS project. I understand that your project has 3 aims. First is to increase the number of persons trained to identify and refer youth at risk for suicide. Second is to increase providers trained to assess, manage, and treat at-risk youth effectively. And finally, you aim to increase the number of at-risk youth identified, referred for, and receiving behavioral health services. And I also understand that in 2010, your state passed legislation mandating annual suicide prevention training for all public middle and high school certified staff and students annually. That's pretty awesome. Congratulations on reaching such a huge milestone. Is there anything you'd like to add to what I've shared about your program?
Yes, I'd like to talk a little bit about the a number of components to address the outcomes you mentioned above, but I'd like to specifically mention our military component, our LGBTQ component, and our statewide school-based implementation project that we've just completed. Also, in March, Kentucky became the second state in the nation to pass a law requiring all mental health providers to have 6 hours of suicide prevention-specific training effective in July of 2015.
That's awesome. Thank you. So let's jump into Kentucky and learn a bit about your work on this topic. So I understand that you've been able to build these collaborative relationships with substance abuse partners. So my first question to you, Patti, is what prompted you to consider collaborating with your substance abuse partners? I mean, is that something that you had to do? Was there a particular reason that you went after that type of collaborative relationship?
I think the biggest reason is that my initial experience in prevention was in substance abuse prevention. So I was very aware of that infrastructure. So in Kentucky, each of the 14 regional community mental health centers has a regional prevention center attached. And those RPCs are responsible for providing substance abuse prevention at the community level. They understand the importance of community coalitions, and they have relationships with the various partners in their communities. I think it was really important that we tapped into this already constructed infrastructure when we began considering ways to increase our suicide prevention efforts and to create synergies in Kentucky. Recent guidelines from SAMHSA, as Eileen mentioned, have shifted the focus of their work to the integration of mental health prevention with substance abuse prevention, and suicide prevention is one of the top priorities of the federal organization. Understanding that perfect storm of shifting priorities and understanding the infrastructure already in place in Kentucky allowed us to begin utilizing the RPCs for our efforts. Initially, we had some issues, though, breaking into using the RPCs for our work. And those initial issues, if you will, were mine. I had some language barriers. I was still talking the RPC language in the suicide prevention world, and we had to shift that so that I was matching both sides of that. Suicide prevention in Kentucky had been mainly focused on the intervention and treatment aspects of the continuum of care. We knew that we needed to begin addressing the prevention aspect, that portion that occurs before an individual finds themselves in imminent risk. To help prevention specialists understand how to do so, we initially began making the connections between suicide prevention and substance abuse. We talked data, including attempt numbers, which allowed them to understand the need for suicide prevention.
So you mentioned needing to shift your language. I just want to talk a little bit about that. When people go to the web pages, they'll learn a bit more about your experience and learn that you, as you said, came out of the substance abuse prevention world. How has your previous experience in that world been useful in moving this collaboration work forward?
As I mentioned before, I understood the planning process that are used with substance abuse prevention professionals. The strategic prevention framework is a huge part of the work that they do. And so I was very aware of how they did their work. But when I came into suicide prevention, the language was very different, and I personally struggled with that. So where substance abuse prevention is focused on the environmental and the community-based processes of creating change behavior, suicide prevention is much more person-focused, ensuring that the at-risk individual gets the help he or she needs to get better. The language barrier represented a hurdle to overcome in order to develop a collaborative approach to suicide prevention. I had to begin talking I had to talk suicide prevention in the substance abuse prevention language.
That's a big barrier, a challenge that we've heard throughout this project. I just want to point out a resource, an example of a resource that we have available to you guys on the web pages. What you're looking at in front of you is sort of a cheat sheet, a crosswalk between suicide prevention and substance abuse worlds along some very common concepts. So you'll see, we have recovery, prevention, risk factors, protective factors on this table, and other terms. I believe this handout is maybe 2-3 pages long. And you quickly realize that we both mean different things. When I say recovery, using my substance abuse hat, it's going to look and feel and mean something very different to all of you as suicide prevention folks. So this is one of the resources that we have available to you that you can reference and print. But it sounds, going back to you, Patti, that you were able to overcome a lot of these language issues because of your previous experience and your agility and moving back and forth between the two worlds. Let's talk a bit about some of the advantages to taking that leap and being that translator. Let me just... what were some of the advantages that you experienced in your project?
One of the biggest advantage was our ability to expand our capacity as a result of reaching out to our substance abuse partners. By understanding their process for utilization of resources, we've been able to tap into their system already in place and in effect multiply our workforce by nearly 50 people. When you consider that we had one before we received our GLS grant, adding 50 people to our staff was tremendous. Kentucky has 14 regional prevention centers, and most have 2 to 3 prevention specialists each, so being able to tap into their abilities and their connections in their communities was huge for us. In the previous grant, legislation requiring school trainings was approved, and several of our schools stepped up to the plate and began implementing suicide prevention efforts in their districts. After several years of state staff providing these trainings, we knew we had to find a better way to meet the growing demand. As more and more schools began to step up and do the trainings, and specifically face-to-face trainings, to be able to provide the information related to policies and procedures, more and more of them were requesting trainings from us. So we knew we had to find a way to increase our capacity. By tapping into the RPC system, we were able to utilize their relationships and community-level expertise to provide 14 T4T trainings to school and community staff members. This summer, we trained 597 people to return to their school district and train staff and coordinate suicide prevention efforts for students. We are anticipating total reach from this effort of close to 250,000 students across the Commonwealth. This is something that would not have been at all possible if we had not tapped into the capacity of our RPCs. Understanding that, I'm sorry?
Oh, I was just going to say that's an amazing and dramatic increase of your capacity and your reach. That's wonderful.
It's absolutely amazing for us to consider the possibility that we're impacting that many kids' lives. But it's also important to understand the goals and outcomes expected by the prevention specialists allowed us to modify our approaches and strategies to create these partnerships. The messages we gave out never changed, but we simply shifted our vocabulary in order to be heard by the substance abuse field. It's also important to note that there's been extensive work in suicide prevention done in Kentucky prior to and as part of the previous GLS grant. That foundation was vitally important to our efforts. We had 400 trained gatekeepers in the state and several schools that had significantly bought into the process of educating staff and students to increase safety of those in their communities. Our work with the RPCs was the next layer to this work and builds upon rather than replaces those previous efforts.
That's really impressive, Patti, and I just want to also reiterate what you're saying, that this really isn't asking people to start from scratch. I know that people on our call today have likely spent a lot of time and effort in their projects building capacity and training folks, but what you're really describing is supplementing work that you're doing and maybe perhaps filling gaps with substance abuse partners, which I think you guys have been able to do really beautifully. So I just wanted to kind of recap what you're saying in terms of how this helped your project. It sounds like your experience in this, or at least understanding the substance abuse world, helped you understand the existing infrastructures. You talked about SPIF, the planning framework that we use in substance abuse, and having that knowledge really allowed you to identify those natural points of collaboration. It sounds like you were able to connect with people using their language and their framework, and this is where I would encourage folks to find those partners, those champions with whom you have relationships that can do kind of this translational work for you that becomes really, really important. And ultimately, you were able to capitalize on your substance abuse partners' infrastructure and really, really in a very dramatic fashion increase your capacity to get suicide prevention work into your communities, which I think is absolutely stunning and wonderful, the way that you guys were able to do that. So it's not all easy, as you know, Patti, and you've probably lived through and experienced. So let's talk a bit about the challenges to taking something like this on. So what, in your experience, Patti, have been places where you found yourself getting stuck? And maybe if it wasn't you and your team, where have you observed other people getting stuck? What are the barriers?
I think one of the first of those is always time. There are so many requirements already in place for those working in the substance abuse prevention field that we have to be aware of their limitations. Their workforces have been reduced due to fiscal constraints, and they're being asked to undertake a myriad of projects. So it was important that we didn't ask them to roll out these efforts on their own, only to help facilitate the process, only to connect us with the community members and to create that network or that bridge, if you will. We were also able to provide them with guidance and support along the way, and also to provide financial assistance. So there was a two-way process, if you will, so that both of us were getting part of our outcomes met from the relationship. Funding is always a barrier as well, which makes it also important to make the connection between suicide prevention and other substance abuse issues, such as underage drinking and prescription drug diversion. These two are hot-button items in Kentucky right now and have been identified by the Strategic Prevention Framework Needs Assessment Process as focus efforts. Understanding the outcomes required of our other partners in the process allows for us to braid our funds and our other resources. For example, somebody may be holding a forum or a conference that we can kind of add our information into or be a part of their activities, and then we can be integrated into any additional conferences or events that are coming up so that we're both maximizing our efforts. While our goals never change to reduce the number of people who die by suicide, we understand that by addressing the various risk factors for suicide, we can effectively enlarge our efforts and tap into systems and processes that are already in place. And then I think one of the biggest is the lack of understanding of suicide prevention efforts can be a factor. The myth that a person who wants to die by suicide can't be stopped, that suicide can't be prevented, permeates society. Helping our prevention specialists understand that these are in fact myths and efforts can be made to decrease suicide deaths is imperative. In some cases, it's also the factor of numbers. Across Kentucky, the average number of deaths by suicide is 600 each year. So that means in most of our communities, the number is actually very small. And when you utilize a needs assessment process such as that from the Strategic Prevention Framework, suicide prevention will almost always fall low on the list of identified needs when it comes to determining how you're going to use your resources. But when you add in the attempt numbers as well as compare rates for each region, you quickly begin to see the hot spots for death by suicide. And prevention specialists are also trained to see those too. Helping them understand the available measures related to suicide prevention is an important part of elevating the inclusion of suicide prevention in connection with other community prevention efforts. So in effect, giving them the tools they need to be able to show why suicide is definitely an important topic for them to consider is a way to be able to braid these efforts as well.
Yeah, I just to echo what you were saying about the assessment process. I mean, and the SPIF does in fact have you start with assessment, and it's very, it's all data driven, and that's a very concrete example of kind of where the two worlds need to have, you have to talk through that, because it may not just by numbers alone, like you're saying, hit number one on the priority list, but there's other ways of understanding the needs of the community. So I like that you pointed that out. So we, in this, over the past year, we talked to probably some of you guys on the phone today and heard some additional challenges in this type of collaborative work. Some of them Patti's already touched on, the absence of shared goals, which, could be mitigated by finding those opportunities to collaborate, like doing a conference or changing language to understand that we're all after the same goal here. Inadequate training, inadequate cross-training is something that we heard a lot of. The substance abuse people will say the suicide prevention people don't quite understand what we're doing, and vice versa. So really finding opportunities to do cross-training seems to be needed in a place where people get stuck. And then, of course, we all know we will always have political resistance, leadership issues, and turf issues involved in this type of work. And that's some other things that we heard during our work on this project. So let's just touch briefly on some of the benefits to kind of soldiering through these struggles. How would you say this collaboration, in addition to that expanded capacity, how would you say this has strengthened your suicide prevention work?
I think that we originally we offered mini grants to our RPCs to begin their suicide prevention program, and this allowed us to be able to see where their strengths and weaknesses were. We saw that through the fact that some of them coordinated gatekeeper training, others developed PSAs, others utilized existing youth groups to develop their parent outreach programs, and it allowed us to get to know each other as well. They knew me. I've worked with many of them before, but in my role as the suicide prevention coordinator for our grant, I was an unknown entity, if you will. I was coming to them from the state level as opposed to a peer or colleague. And these mini grants were just an opportunity for us to get to know each other and to get some quick successes under our belt so that we can begin to embark on this larger project that I talked about where we trained the 597 people this summer.
I love how the mini grants really help to build, gave people a reason to work together and really help build that trust and those relationships with each RPC. Thank you for sharing that. So I'm going to now start introducing this, our SPRC Substance Abuse and Suicide Prevention Collaboration Continuum. It's a mouthful. So what you're looking at in front of you are the 4 stages that we've used really to organize all the concepts involved with this type of work. We're not going to go in too much detail about the actual content, but it's organized along these 4 stages. Patti, where would you say you are in this continuum? Where is your collaboration today?
I think it's important for everybody to realize that we've moved all the way across the continuum, and depending on the RPC that we're working with, we may be at different stages. So it's important not to kind of push yourself into one of those categories or the other. You may be at different levels based on your relationship. It's imperative when we're considering our partnerships and collaborations that our parties meet each other where they're at on an issue. For example, there are many people who are concerned about addressing suicide, and so we have to give them the opportunity to come into the process where they are and where they're comfortable. This increases the opportunity for buy-in and investment into the process, and also it increases the likelihood that efforts will become institutionalized and sustained beyond maybe current funding mechanisms.
Yeah, and again, just to echo all the stuff you're saying, Patti, meeting people where they're at is really, really, really important in this type of work. I'm going to thank you so much, Patti. I'm going to start talking more about the continuum, but before I move us on, is there anything else you'd like to share about this work that I haven't asked you about?
I just think it's vitally important that we understand that both sides of the process, suicide prevention as well as substance abuse prevention, have goals and outcomes that we are directed to meet, and understanding and honoring these requirements is vitally important in developing these cross collaborations. The end goal should be that both sets of goals are being met and both parties are seeing successes as a result of the collaboration. Only with collaboration can we see the results that are needed if we are ever to make the impacts we need to make on both suicide deaths and substance abuse.
Well said, Patti. Thank you. Thank you. At this point, let's take a pause here for some questions, and I believe Ellie's going to help us with that. Do we have any questions?
Actually, this is Ellie. We have someone shared their experience. So I'd encourage, we do have a couple moments for questions if people have any questions for Patti. But while you're typing those in, I just wanted to share, Eileen Gibbons shared a little bit about her project where they have an MOU with the local youth and adult treatment center. And an alcohol prevention program so that they go into schools together with the alcohol prevention folks and have a really collaborative effort. And she was mentioning that they're very aware in their community how connected alcohol is to suicide, and that cross-training is included in their MOU. So thanks so much for sharing that, Elaine. And you know, if you have stories like that, we'd be very interested to hear them. Feel free to share them with your prevention specialist, because you'll see we have some stories on the website, but we'd love to beef those up a bit, because the more examples we have, the better. So I'm not going to spend too much more time here because I don't see any more questions coming up. So Tahoot, I'm going to hand it back to you to give people a sense of the new web pages.
Great. Okay. We are going to go. So we're going to take you on a little tour of the web pages. We're not going to go through everything extensively, but just to familiarize you with how it's laid out. Can everybody see the screen? Looks like, okay.
Yes.
So, great. So this is the opening page of the Substance Abuse and Suicide Prevention Collaboration Continuum web pages. Again, you'll see the 4 stages of the model in front of you. There's also a PDF on this page that a lot of the juicy details around each stage, which we're pulling up right now. You can print that and take a closer look at what each stage entails and steps on moving your collaboration forward. Maybe you're coming to this not really understanding or having given thought to where you might be on this model. We have a self-assessment tool also on this page that you can use. This would be a great thing to use with your team, with a partner that you're working with. Just ask you some questions, very simple document here that asks you if certain characteristics exist in your current partnership. It will help you at least get a general sense of where you might want to start your work. So we'll go, that's on the landing page as well. So we'll go now to a sub-page. So all of the pages are sort of laid out the same way. So I'm going to take you to the contemplating page here, which is the first stage of our model. So you can take a look at what the pages contain. You'll see there's a definition right under the picture with some descriptive bullets of what each stage looks like. And to the right, you'll see some of the case examples that we found. And Ellie said, you know, if you have examples, we would love to collect these stories and make them available to all of your peers. That's on the right-hand side. Scrolling down, you'll see that we have resources at the bottom of the page, and this is where you'll find all sorts of printable PDFs that you can use right away to do various things. So we can take a look at one of these tools. Let's take a look at the Identifying Promising Partners tool. So again, a printable PDF that you can use with your team. So the purpose of this particular tool is to think through potential partners you may know in your community and evaluate them along some criteria. So the idea being that you can kind of think through who you might want to reach out to before you start doing that, just so you don't have false starts or time and effort into reaching out to someone that doesn't pan out. It's not a useful relationship. So that's available to you on the website as well, along with a whole host of other tools. So the last thing I want to show you here is one of these videos. So for that, let's go to the cooperating page. We're going to take a look at a video from our Alaska tribal grantee, Melanie, and in this video she talks about what prompted them to start thinking about collaborating with substance abuse partners. So let's take a listen.
And this is Dominique just mentioning, for those of you who have called into the phone line, you will need to turn on your computer speakers in order to hear the video. So we will go ahead and play it right now.
Our recidivism rate was really what drove us. We have patients who are readmitted to our substance abuse treatment center sometimes multiple times, and so what are we missing? So internally, we did some mining of our data to find out that our rate is very, very high. Recidivism rate in those who have underlying mental health issues that haven't been addressed. So we think that until you address both issues, you really won't make progress, and the patients really won't make progress.
Great.
Okay. So that's what I wanted to share from the web pages. I really encourage you guys to spend some time exploring what's there, and you know, it may give you some ideas for your efforts for your projects. And also, it's kind of nice to hear what some of your peers are doing in the field. So check out those videos. So that's it for me. Thank you so much for your time, everybody. I'll turn things back over to you, Ellie.
Great. Thanks so much, Tehoot. So that's about the end of our webinar. If you have any late-breaking questions, please do type them in as I'm sort of wrapping up. And in the meantime, I just want to thank you for coming to the webinar and encourage you to complete the evaluation you're going to get today on how the webinar went for you. And of course, your feedback helps us keep improving these events for you and your colleagues in the grant program. And I also encourage you to explore the Collaboration Continuum web pages. You can either go to our homepage that's listed here and click on States and Communities, and you'll see it in the left-hand navigation. And also, when we close down this webinar, if your computer is still on, it will pop up in your browser so you can take a look at it right after the webinar. And as I mentioned before, we really are interested, especially for those of you who are already collaborating in this way, in hearing more about your experiences and stories. Because for those folks who are just getting started, I think the more examples they can hear and different strategies, the easier it will be for them to start their efforts. So please let your PS know if you'd be willing to share your story, and we would love to add your strategies and experiences to these pages. And here is our contact information. Please feel free to get in touch with any of us or your prevention specialist with any questions or comments or stories to share. And I want to thank all our presenters for taking the time to be with us today, and thanks all of you who are joining us as well. We appreciate your taking the time out of your busy day, and we hope you have a great rest of your week.